Well, good morning, everybody. Thanks for coming out. Thanks for the nice introduction and for the invitation to come, Julia. It's a pleasure to be here and to speak here as one of three speakers on the Ebola workshop. I work a long time on Ebola. I guess I forgot when I started. I think it was at the end of the 80s at a time where no one cared about Ebola. We even didn't have spots on virology meeting. We were in the retrovirus groups or paramyxovirus groups. So things have changed over time. Today, Ebola is usually in everybody's mouths and everybody's speaking about it. So what I'm planning to do is to come a little bit from discovery, and then in the second part, I'll talk a little bit about the VSV vaccine, which it took us almost 25 years or so to work on, not just us, with many colleagues. And then I will leave the therapy up to the following speaker and the ecology to the other speaker. So I will touch it only very briefly in my talk. I thought I'd start with a little video clip. And this video clip comes from Guido van der Gruen, who is in the bottom right. Guido is one of the co-discoverers. He's from the Institute of Antwerp, and he wrote a book on Ebola. And on the upper left, you see the Ebola River, where ebolavirus was named after. And Ebola was discovered in '76. Later on, people found out, or the first generation filovirologists found out that these were actually two outbreaks, and one was caused by Zaire ebolavirus, one was caused by Sudan ebolavirus. So the one in Sudan was in southern Sudan, which is now South Sudan, and the one with Zaire was in northern Zaire, which is now called the Democratic Republic of the Congo. If you're interested in the discovery history, because there were some disputes during the West African outbreak, there's a JID paper, it's mentioned in the bottom left, so you can read more about the discovery of Ebola. So I hope that video plays.
In the third quarter of 1976, an unknown devastating disease strikes the area of the Yambuku mission in northern Zaire. A number of local people having died already, it is the death of Belgian missionaries that alarms the international community. In September, a Zairean professor visits Yambuku and evacuates Belgian missionaries to Kinshasa. Mid-October, an international scientific commission led by Carl Johnson arrives in Zaire. This film contains unique footage.
That's not Carl.
With a first-generation camera by a commission member, Guido van der Gruen. On September 19, the first Belgian, Sister Beata, dies. 11 days later, Sister Miriam collapses in the Kinshasa hospital she has been taken to by Professor Muwembe. From her blood, the Ebola virus will shortly after be isolated at the Tropical Institute of Medicine in Antwerp, the home ground of Guido van der Gruen, who set up laboratories in Kinshasa and Yambuku, and along the way developed a side career as a cameraman. Gradually it dawns to the scientists that the epidemic had already died down by the time they got to the Yambuku region, which quickly recuperates. But having so few actual patients to study did not facilitate the job of Carl Johnson's team.
What we learned, for example, about the virology of the disease in man was limited to nurse Monica.
Well, I stop it here, and what Carl was alluding to is what we worked with until, I would say, the early 2000s. Everything was done with that one isolate, which was from that nurse, Mayinga, and everything we knew was related or was going back to that particular isolate. Another thing that the video mentions is the international community usually gets involved when these outbreaks are either at the peak or past the peak. And that has not really changed, except for West Africa and now DRC, where the outbreaks are expanding over years. But all the previous outbreaks, the international teams would either come at peak or past peak into the area. We should not forget that Ebola was not the first filovirus to be discovered. 9 years before, in '67, Marburg was discovered in Europe, Marburg, Germany. That's where the name comes from. But if you look at the family and in the genus Ebola virus, we have 5 distinct species. You may think there's 6 now, but the 6th, I mentioned it in a following slide, is still tentative, is not accepted by the ICTV. So we have Zaire and Sudan Ebola virus, which were both discovered in 76. But when we talk about Ebola these days, or what the normal person means, is always Zaire Ebola virus. So Ebola virus relates to Zaire Ebola virus. Then we have Typhorus Ebola virus and Bundibugyo Ebola virus. Those 4 are found in Central Africa, and they are associated with human disease. For Typhorus, there's only 1 case, and perhaps a retrospective case. WHO mentions it, CDC doesn't count it. So we don't really know anything about Typhorus. And then there is Reston virus, and I will come back to Reston in a second. So the map shows the outbreak regions where these viruses have caused human disease. Red is Zaire Ebola virus, and that was largely in the western part of Central Africa until West Africa popped up, which is the Zaire Ebola virus, and now the DRC in the northeastern part. So Zaire has really expanded to the west as well as to the east. Bundibugyo and Sudan, that's blue and yellow, have been naturally found more in the eastern part of Central Africa. The current outbreak, you may follow it, has over 3,000 cases. It's the 2nd biggest one on record already. Has about 2,000 and some deaths already. Healthcare workers are affected again, which is a hallmark of Ebola outbreaks. And case fatality rate is currently around 65%, which is a little higher than West Africa overall, but much lower than the previous outbreaks, which were around 70, 80, 90% at times. For the first time, this outbreak was dealt with vaccination, and I'll come back to that, as well as with treatment, and that is a unique phenomenon. You may say this happened already in West Africa, but that was at the tail end, not at the beginning. A few words about Reston Ebola virus. So Reston popped up in '89 in the US. It was introduced through monkeys from the Philippines. It was then reintroduced later on into the US and also into Europe. Italy is mentioned here, but there is also documentation that it might have been introduced into Germany, but nothing is published on that. Generally, people believe that Reston is apathogenic for humans, and we don't really have any disease, but we know that Reston can infect humans. There is data on that, but the data is still very weak. But a shock came in 2008 when the Philippines reported Reston Ebola virus in pigs. And still today, it's not really known what this virus does, because it co-circulated in pigs with PRRS, a highly pathogenic virus for pigs. And the role of Reston is still not really studied these days, and no one knows. But the big concern was food safety. And what would happen if that virus would be brought into the human population? Could there be a mutation? Could there be an adaptation? And that jury is still out. Some countries in the world have downgraded Reston to a level 2 virus. I think this is a little premature in my view, but that's what it is. But in the US, it's still a level 4 pathogen. In terms of the reservoir, I leave this up to one of the following talks. Just wanted to say that the general belief today is that bats are at least a reservoir. And bats, of course, is a big word. There is so many species, and we don't really know what species are or might be involved. Keep in mind, up to date, at least to my knowledge, not a single Ebola virus has been isolated from any bat. We have serological data, we have PCR data, so genetic data, but no isolation. That's different from Marburg. Marburg has been isolated from Rosetus aegyptiacus, which seems to be one of the prime reservoirs, but not any of the Ebolas, and that is still a big mystery that needs to be solved. We have more filoviruses today. People call them viruses. I call them sequences because no isolation for any of them. We have Bombali virus, which comes from bats in Africa, and this is the new proposed species of Ebola, so the 6th one, but no virus yet. We have Uvio virus, which was a little earlier from Spain, now also in Hungary Hungary, and it represents a new genus, but no virus. We have no virus. We have only sequences. And then there's Mengele virus, which comes from China. Again, a new genus. And then there is even 2 genera of fish filoviruses now that are listed in the taxonomy. So there's lots to do on the ecology side, so the next years have to show what the human pathogenic potential of these viruses might be. But we need viruses for that. Maybe we can use reverse genetics to solve that problem if we can't isolate the virus. So looking at the disease, we have learned much during the West African outbreak. As you may remember, Ebola caused Ebola hemorrhagic fever in former days. Now the disease is called ebolavirus disease. And what this does is it just reflects more of what's actually been seen in the field, particularly in West Africa, particularly now in the DRC. We see a huge variation of clinical symptoms, and particularly the hemorrhagic manifestations, which are only found in 50 or even less than 50% in the humans as obvious signs. Clinical signs do not appear. Incubation period is thought to be somewhere between 3 and 21 days, in medium around 9 days, and it is generally believed that there's no transmission during that incubation period. But you can't count on that, but that's what we generally believe. The early phase is very difficult for diagnostic purposes because it just mimics any type of tropical or subtropical infectious disease, particularly malaria, typhoid fever, and so on. So diagnostic plays a big role, and we have come a long way. I think we're pretty good in diagnosing Ebola these days based on genetic approaches. When you get into the second week of the disease, you see the effect on all the organ systems with Ebola, and that's when you also see hemorrhages should they occur. So there's issues with liver due to virus replication. There's coagulopathies. There's vascular leakage, a multi-organ infection, and a multi-organ failure that ends up in shock and in lethality. But we also have learned that a lot of people survive, particularly now since we have treatment and since we have vaccines that can interfere. And one of the outcomes of studying those survivors is the post-Ebola syndrome. Post-Ebola syndrome summarizes clinical signs that affect mental health and physical health, and that also affect the community integration. Community integration of survivors has been a big problem throughout the early outbreaks, and I do not know personally how big the problem is, but I don't think it has been solved. So this is a huge issue, bringing back survivors of Ebola into local rural communities because they don't really want them, because they are afraid of getting Ebola. The other problem that popped up, even so we had heard about it before, is sexual transmission and the persistence of Ebola in immunoprivileged sites, such as the eye or the testes of men. We have PCR positivity of semen up to 560 days. I think this is the longest I've found so far, which means PCR. This does not necessarily mean infectious virus, but we know of a few transmission chains. You may ask yourself, what does it contribute to an outbreak, sexual transmission? I would say little to nothing. But one event could be a huge public health disaster, and that's why we have to take it seriously, and why we do, and why WHO does take it seriously. One event could start a new outbreak, could restart an outbreak that is literally done. So you don't need many to get a disaster. Talked before about diagnostic capacity. This was introduced in the early 2000s, heavily funded by biodefense initiatives. I think in the forefront were CDC always, since a long time, but also the Canadian laboratory. And then since the West African outbreak, the European laboratories. We have mobile laboratories that can move into very remote areas, doing literally PCR assays to diagnose Ebola. And that is enough. That's all we need for the diagnosis in outbreak situations. In West Africa, we also introduced sequencing approaches, and they were extremely helpful for surveillance efforts and transmission chains and where viruses came from and how they travel through the human population. We also have bedside tests now that detect antigen and also immune responses, even so immune response is not that important for diagnostics in an outbreak situation. One thing that we should not forget, I've been on many outbreaks, and I would call West Africa a luxurious outbreak. Most of the sites were in big towns where we had infrastructure. The previous outbreaks were in very rural areas. We had no infrastructure. So I'm a little doubtful how well we can introduce sequencing into one of those more rural places. But we can certainly send these mobile labs. We have introduced blood chemistry into the diagnostic pattern. But despite all of this, and these are data from our lab in Monrovia in 2015, 14, and 15, 50% of the patients that showed up as clinically suspect Ebola in the ETU were not Ebola. And that is a huge, huge problem. So they fit the clinical case definition, end up in the ward, get exposed to real Ebola, and may catch it there. And this is something that needs to change. We are pretty good, meanwhile, with one of the key differentials, which is malaria. But there's more than that. And so we need to get better in terms of differential diagnosis and keeping those that don't have Ebola out of the ETUs so that they don't get Ebola. If you want to do countermeasurements, we still need animal models. And we're very lucky if we talk about Ebola in particular, but also Marburg. We have plenty. We have small animal models, all kinds of different rodents. The problem with those is that they usually, if they're immunocompetent, need adapted virus. You have to adapt the virus, the wild-type viruses, through passaging for these immunocompetent rodents. We have the non-human primate models, usually cynos and rhesus, that can be infected, lethally infected, with wild-type isolates from humans. And now recently, we also have the ferret model. But the jury is still out on how useful that model really is. But it utilizes wild-type viruses. In that sense, it is better than the rodent models. Of course, to handle a ferret in high containment is not the easiest. So mice are a little bit easier to do. Don't read the table. It's all published anyway. But I just wanted to mention that we have a lot of models to do countermeasure development, to study pathogenesis. But during the West African outbreak, people start crying. We need better models, because all of these models were set up for uniform lethality or very severe disease. And as I've told you, we have survivors now, 40% or whatever surviving. So they want now models that mimic disease progression in humans, particularly for therapeutic development. And I understand their request, but it is not so easy to do in high containment, particularly if you look at non-human primates in terms of animal numbers in BSL-4. So that will take some time. Just a few words on treatment. I leave this up to the next speaker to go into more details. I think the front runners are the antibodies. They have clearly shown, particularly in preclinical studies, high efficacy and can be given very, very late. One day before you have to euthanize these animals due to humane endpoint criteria, you can still have impact with these antibodies. So they're clearly, in my view, the front runners. They come in cocktails, they come in single application, which surprises me a little bit that a single monoclonal is doing it. But MAB114 is an example for that. But we also have the antivirals, or what I call the classical antivirals that interfere with the virus replication. On top there are the nucleotide or nucleoside analogs, and we will hear more about remdesivir, I'm pretty sure, in the next talk. But there's also siRNA and there's PMOs. If you really think about it, that these ones are a little bit less potent in comparison is not that big of a surprise, at least in my view. They have, in preclinical studies, what I would call moderate efficacy. They have to be given earlier. but it's a totally different drug. The development is different, the costs are likely different. I'm not in that area, but I think it is a big mistake if we count them off at this point. This is really, really important, and one thing that should not be overseen is they'll most likely work against all the filoviruses, whereas the antibodies are very highly specific to one species, and that's a big, big difference. So don't forget about those. They started testing clinical trials in West Africa. And I give you my summary. I don't think we learned too much about it because it was too late. We didn't have enough patients to look at, and then there was a lot of critique on the study design. I don't want to go into details. We can do that in the discussion. They picked it up again, and the PALM trial is an example here in the DRC right now, and this one is still ongoing. But we had some preliminary data made public in August. 3 monoclonal preparations and remdesivir were used, and it looked like, at least by the preliminary data, and that is also published now, that MAB114 as well as the Regeneron cocktail are more efficacious than the other two, and those two are continued. The other ones have been stopped as far as I know. Again, I wouldn't discount or count off the nucleotide analogs at this time. I think we really need to keep them in our repertoire. The question why ZMAP did not perform as well, I can't answer at this point. I think there is a lot to say too, and we have to wait what the future is going to bring us. One thing that really needs to be tackled is combination therapy, and it's just being started on preclinical level from what I have been hearing lately. Coming over or getting to the vaccines. When I started in the field, my mentors, such as Bob Swanepoel, C.J. Peters, they all told me, forget about vaccines. There's no interest. There's not enough cases. The people that get Ebola, no one cares about. Industry has, there's no interest, there's no market, and we don't really need them. We have isolation, we can deal with the outbreaks. That was the answer. But interestingly, if you go back, countermeasure development started literally with the day of discovery. So we had experimental approaches all along. This changed in the early 2000s with the biodefense. Western governments wanted countermeasures against potential biothreat pathogens. Ebola was one of them, maybe the top one, but there is also others to mention, and that really paved the way to what we are using today or what we have optimized until today. And then West Africa really showed what the targets group might be for vaccination, in particular our aid workers in many functions and the family members and so on and the surrounding community. So nowadays, no one is really questioning vaccines any longer or treatment for Ebola or similar diseases. When we got involved was also through the biothreat and defense activities back in early 2000 when I worked for the Public Health Agency of Canada. I'd never done any vaccine work, but we were asked to look into it. And our concept was emergency vaccination. We thought this is the only way that will make sense, and it has to be a vaccine that has to be given once because you'll never see the vaccine the second time. So our model was the ring vaccination that helped to eradicate smallpox, or the rabies post-exposure, which is a vaccine in combination with antibodies. So these were kind of the goals. So we said, okay, this can only be achieved through a live attenuated vaccine, and these were our criteria that we set out. Live attenuated filoviruses were not an option due to safety risk, so it had to be another vector, and we chose the VSV, vesicular stomatitis virus. So this is the cartoon of the genome, very simple. It's a raptovirus, as you all know, kind of similar to Ebola. Some people may say, others would heavily complain when I say that. But keep in mind, we were raptovirologists in the early days. So what we do with this, we genetically engineer gene 4, which expresses the VSV-G, and then we put the ebolavirus glycoprotein in there. That was the approach that we took. This system came out of Jack Rose's lab. Jack was not the only lab that worked on the reverse genetics, but he published in '96 the reverse genetic system based on the Indiana serotype. And then reverse genetics is in all people's thinking these days, so I don't have the time to get into. So through plasmid transfection into cells, we can, and manipulation of the genome, we can make a recombinant VSV. In this case, that carries on the surface the ebolavirus glycoprotein or the Lassa virus glycoprotein instead of the VSV glycoprotein. We chose this approach because VSV-G is associated with pathogenicity, neurotoxicity, and neuroinvasion. So the G is out of the equation in this particular vector. But this work started before the vaccine came into play. I was in Marburg, Germany, working under Hans-Dieter Klenk, who is the Wright Fellow there, together with Viktor Volchkov, who came from Novosibirsk, from the Marburg and Ebola Center there, who worked with us in Marburg. We were basic virologists. We were interested to use the system to study the function of the glycoprotein in vitro and to look for virus entry and cell toxicity. So that was the purpose at that time.